Hello, and welcome to the Alabama Public Health Training Network. I'm Brandon Vaughn with the Alabama Department of Public Health. Thank you for joining us for our program today, Adolescent Addiction, Where It All Starts. If you have a question about anything being discussed today, please call or email during our broadcast. The phone number and email address are on your screen now and will appear again later in the program. Also, the handouts, sign-in sheet, and evaluation are all available online. You will need to register for this program in order to access those materials. Continuing education credits have been approved for nurses and social workers for this program. In order to receive credit for this training, you must watch the entire program, then complete and return the sign-in sheet and evaluation. While content may continue to be relevant, CE credit will only be awarded for 2 years for nurses and social workers, expiring on October 31st, 2021. If you're watching this program on demand and want to receive a social work CE certificate, you will need to complete the social work test and send it in, along with your sign-in sheet and evaluation. If you're watching this program live, there is no social work test required. For social workers, if you are watching this program live, it qualifies for classroom hours. If you are watching on demand, it is considered non-classroom hours. Before we get started, I'd like to introduce our presenter today. Dr. James Harrow is the Medical Director at the Baptist Medical Center for Addiction Recovery. Welcome, Dr. Harrow, and thank you for being here today.
Thank you. I'm Jim Harrow. I'm a physician, and as I was introduced, I am the current Medical Director of the Baptist Health Center, Baptist South, and the Baptist System in Montgomery. And we've been around now for a little over a year. But in that process, I had the pleasure of meeting Glenda Stanley and Elena Kidd, who are my audience this afternoon. And through that conversation, we decided that it would be kind of interest to present a topic that is to do with addiction, which clearly is on everybody's mind today, given the opioid epidemic. So that's who I am. I have no disclosures. These are some of the objectives that I hope to get through today. And when I've been practicing medicine for about 3 decades, and when I think of human disease, it has to start somewhere. And I found this on the internet, and I thought it was appropriate given the topic of the onset of addiction in the adolescent population. And if we think of disease states and what does modern medicine really do, and I had to reflect on that, there's very little that modern medicine actually cures. The vast majority of the illnesses that we suffer as humans are chronic. And yes, we may cure some infectious diseases, and we may cure some surgical illnesses, and some malignancies may be curable. But when I really look at my own experience, the vast majority of my patients suffered chronic disease, and addiction is really no different. So is addiction a brain disease? For decades, and in fact, for a century or more, addiction was aligned with the psychiatric medical community. And I will be very bold to tell you that addiction is not a psychiatric illness. It is a neurologic disease that has behavioral as well as physical manifestations, as all diseases do. So the developing brain particularly is where we're going to draw our attention to this afternoon. What happens in adolescence, defined as between the ages of 12 and 19, when the developing brain is exposed to substances, as we say, substances of abuse or substances of addiction, including alcohol. And we have to have a little bit of understanding and background of the human brain and its development. There are 2 basic parts of the human brain that we're going to discuss this afternoon, and one is the prefrontal cortex, and the other is the mesolimbic reward system, and how they interact together, and how addiction is thought to occur. Because the evidence we have is not necessarily circumstantial, but is animal-directed, and then observation in humans and understanding the anatomy and the neurophysiology of the human brain. So the prefrontal cortex is that part of our brain that is the executive center. It allows us to make rational, hopefully healthy decisions to carry out a certain behavior. And as a diagram suggests or shows you, there are anatomic parts of the human brain The blue part is the prefrontal cortex. That is behind the anterior portion of the brain, which is behind your forehead. The mesolimbic reward system is where you see memory and is in the center of the brain, and it is subconscious. It is not under conscious control. And the mesolimbic reward system has a variety of names. We call it the mesoencephalon, the midbrain, and people know it as the reptilian brain. And that'll become a little more apparent as we go through our discussion. And the primary transmitter, as you know, that all brain cells talk to each other in a sense, but they do that neurochemically. And they do that through what are called neurotransmitters. And dopamine is cardinal in this situation because it is the neurotransmitter in the mesolimbic reward system. So the adolescent brain, from conception through development through adult life, goes through stages of transformation and change. So if we think about the newborn with very limited cerebral function at that point in an individual's life, progressing through childhood into pubescence and adolescence and the teen years, there are very significant changes that occur. You know, we're endowed with so many brain cells, not all of them are being used. And the concept that has been formulated over time is that as the brain forms, it produces connections. It has a wiring circuit. And the brain is an electrical organ, so the brain talks to itself. Through the cell body has an axon, which is like the wiring, and it has dendrites. So in those cell bodies is the information that is, over time, is assessed and stored in the human brain as we understand it. So during the adolescent period, all these circuits are being established. And through learning and through storage of information, we begin to see and begin to understand that the development of the human brain occurs because of inputs, the digestion of information, and the storage, and then retrieval. And so people talk about sculpting the brain. The brain is not just a stationary organ. It changes. It has plasticity. And so the sculpting of the brain occurs during adolescent development. And so what is this so-called critical period? When one thinks about it, the brain is vulnerable at a certain part. If you look at adult brains, yes, we can learn, and we have inputs, and we have memory, and so forth. But the most critical time is really during adolescent development, when those inputs that are coming in, whether healthy or not, are being stored within the brain tissue. So the prefrontal cortex takes time to develop, and it is affected directly by the addictive process, as well as the midbrain, or the reward system, because of the integral relationship between the two. You know, the midbrain is subconscious, the prefrontal cortex is conscious, and those communications are translated into some type of behavior and some type of activity. So I think of, and others think of the use of substances as the mesolimbic reward system is essentially being hijacked. And let's think about it as with drugs of abuse or addiction and alcohol in that mix. These substances stimulate the mesolimbic reward system. There's a release of dopamine, and people call it our feel-good substance. But it's the neurotransmitter within that region of the human brain and is integral to the development of addiction. And so the mesolimbic reward system is involved in a variety of subconscious activities, namely food, for example. When I'm hungry, I don't say consciously, I'm hungry, and then go and find food. My reward system tells my prefrontal cortex, you're hungry, go and eat. And the same thing pertains to sexual activity. That's an inherent part of being a human. It is under voluntary control in terms of what we do, but the stimulus comes from the reward system. And that's obvious, should be obvious to people in terms of maintaining our species. So and that animal model fits the human circumstance. And so the reward system is just that. And often I think of my own experience and those of others who, through conversation, what is rewarding? Well, we often say to ourselves, well, chocolate's rewarding, or a certain food may be rewarding. And what that does, it makes you feel good. Humans do not like to feel bad. We like a sensation of feeling, let's call it just feeling good. And if you've had that drink when you were, a drink of alcohol when you were 14, what did it do to you as opposed to what it did for you? It's rewarding. It made you feel different, made you feel good. But over time, that stimulus that keeps on going to the mesolimbic reward system will eventually lead to dependence in terms of the structural changes within cells, the genetic information will change, and addiction is thought to then settle in, and it's a chronic disease. So dopamine, is going back to it, remains that rewarding substance. Ultimately, that is what's released into the mesolimbic reward system, specifically the nucleus accumbens is that part of the reward system. And this is repeated over and over again. And the behaviors that occur in that activity are transmitted to the prefrontal cortex and therefore learned. I feel bad, I want to feel better. My brain says, smoke some marijuana, take a drink, swallow a pill, and you will feel better. That is not a conscious response. That response occurs in the reward system, which is then transmitted to higher centers. So reinforcement occurs over time. And so from the initial taking of a substance and or alcohol, that doesn't make an addict. People don't become, it's not like making Kool-Aid. You pour water in and you have your Kool-Aid. This occurs over time with repeated exposure. But there comes a point where the mesolimbic reward system is now fooled into thinking, if you can use that term, that now it's part of our natural reward, when it's not. It's pathologic. But clearly, the addictive process is now telling the organism, the human, that you do this and you'll feel normal. And that, it clearly, is not normal biology. So the changes in the reward system occur over time, and once they establish, you have chronic, lifelong addiction. So it's reward-related learning. Think of our experiences in any type of learning behavior. As a child, I can tell you that when I came home with an A, I got a pat on my back, and usually 25 cents. That was what was available at that time. But if you didn't do well, for example, think of your own experiences. Didn't you hear about it? Well, you didn't get rewarded for not doing well, did we? And that's partly learned over time. So if I do well, I get rewarded. So the midbrain says, you can do well, and this is reinforced over time, and it translates into the behavior. So what's happening at the cellular level becomes translated into what we call addictive behaviors. And the reinforcement occurs over time. That was kind of an overview of the neurobiology, and clearly there's a lot more involved in this that we don't have time for, and it's something that even a lot of people don't understand. Neurobiologists we have limited understanding how the human brain works. It's getting better, but we really don't know all the inside and the intricacies. So what other contributing factors to addiction do we see in this population of adolescents? What other things could drive or promote addiction later in life? And the prenatal exposure, and this I think is fascinating, because as a physician, part of my training and those of other healthcare professionals involved in pregnant women, for example, we are told unequivocally, do not prescribe anything during prenatal development of the fetus, because we don't know what these substances do. So avoid any unnecessary medications during that time because we don't know the effect. Well, the same principle applies to substances of addiction and to alcohol. What do they do in terms of in fetal development, the prenatal period, and do they predispose or do they indeed cause addiction? Well, cause and effect has never been established. So it's, you can't do a trial on pregnant women. Some will drink and some won't, and then look for the end result. I mean, that's absurd. So we have to do longitudinal population studies with women that have used substances and drank alcohol during gestation, and then what happens to the postnatal individual as they develop throughout life and into their adolescent and adult years. Does substance and alcohol use predispose or cause addiction later? And that has not been firmly established. But clearly prenatal alcohol, and there's been some research in this, particularly when you're dealing with the fetal alcohol syndrome. This is well known to most people who deal with mothers that suffer alcoholism, for example. The physical findings are apparent, and it is the leading cause of non-inherited intellectual disabilities. But there's also a thing called fetal alcohol spectrum, which doesn't show the classic physical findings in terms of facial maldevelopment, but clearly will be demonstrated later in life with learning disabilities. So we have some understanding of what alcohol can do. Opioids, we've been in this thing now. We were talking before the session about the opioid epidemic, and we're now well into this thing. We're going on about 25 plus years, and we're still at it. And for mothers who are using opioids during pregnancy, those of us caring for these patients, and for the newborn infant, we're all familiar with neonatal abstinence syndrome. That is, when the mother is using opioids, whether they're prescribed as in methadone or buprenorphine, in terms of treating opioid dependence, opioid addiction, what happens to the developing fetus? Because they're exposed. And when that infant is born, they will go through withdrawal, and that is neonatal abstinence syndrome. There's a lot more to it, but basically that infant is withdrawing from opioids, because the treatment of that infant is to administer an opioid such as morphine. So, but what's going on in terms of development? What's happening to the gestation or to the fetus? Because the stress with the mother going through withdrawal, for example, has been demonstrated to lead to premature labor. That means we have premature infants being born as a result of the stress of withdrawal. The withdrawal in the mother may be minimal. What is the stress to the fetus in terms of withdrawal phenomena? So prenatal opioids are clearly an issue, and we're addressing it in terms of medically assisted treatment in that population to minimize the impact of opioids on the developing fetus and in the birth process and neonatal abstinence syndrome. I mentioned these two medications because now they become ubiquitous in the treatment of medication-assisted treatment of people suffering opioid use disorder. And so therefore, methadone is still the gold standard in terms of that treatment regimen. Buprenorphine came along and is now used in the treatment of the pregnant female and is thought to be a lot safer. There was a study released called the Mother Study a number of years ago which compared methadone and buprenorphine. And so buprenorphine is found to be quite safe in terms of treating the mother. What the effects are on the developing fetus remains to be seen. We just don't know. We can make some guesses. We can say that maybe there might be problems later on with learning and memory deficits, but what are the long-term effects? That remains to be seen. Other things that are related to active addiction in the mother and the developing fetus, I've listed here just a couple. HIV and hepatitis C is very common in the addiction population. But what happens during overdose, which we see on a regular basis? I know we see it in our hospital and it's seen around the country. What happens to anoxic brain injury in the mother? What's the impact on the developing fetus? What are we going to see later on? And that remains to be learned as time goes by. Prenatal marijuana, since marijuana is clearly not addictive, right? It's an herb. It doesn't have any addiction liability, and I'm being facetious for a reason, because it is now becoming, in the view of many, it's epidemic. But people don't understand the impact of THC on the developing fetus. Will there be future behavioral and psychiatric disorders that will emerge in this population as increasingly marijuana is being used by the population as a benign substance. Tobacco has been discussed for decades. There are observations and longitudinal studies that have demonstrated what I've listed on the slide. And methamphetamine and ecstasy, these are psychostimulants. Methamphetamine, at least in my experience here in Montgomery and surrounding areas, would I call it epidemic? It's very common, put it that way. And what are the effects on the developing fetus in terms of those compounds? Methamphetamine is a very potent drug. What does it do to the developing fetus? In animal studies, we have some understanding, but will it result in neurologic impairment later in life? Prenatal cocaine, we go back to the 1980s, and for those of us that were around at that time, we remember the crack babies, as they were called, which I thought was a rather derogatory term. But nonetheless, we saw that. And there was a lot of public commentary and within the news and so forth. From a medical perspective, often these individuals that were using cocaine were also engaged in other substances. So collectively, what did that do to the developing fetus in terms of neurologic function later in life? And, you know, we don't really know. I think there's clearly some evidence later on that there's a reduction in learning capability as measured through IQ scores, etc. But I think that we still are at the stage that we don't have a clear understanding of long-term effects. Fetal distress of any kind. Does it predispose to a substance use disorder? Exclusive of drugs of addiction and alcohol, what happens during the fetal development that may stress the fetus in terms of maternal illness, for example, or reduce oxygen tensions because of some circumstance? Does that produce later behavioral and learning disabilities is also in question, and I think over time we're going to be seeing those results. So, is addiction a developmental disorder? This is an old slide. It's from DSM-4 in 2003, but it shows something that is applicable to all substances of addiction, including alcohol. The peak period for risk is about age 17. So from about age 12 to 17, there's a steep rise, and then a rapid decline to about age 23, 24. And what's interesting is that the brain development is occurring very rapidly during that time period. The human brain doesn't complete its development, at least in males about age 26, females about age 24, 25. So at that period in life is when the brain seems to be most susceptible to exposure. When exposure occurs, will addiction occur? Prefrontal cortex, as I mentioned, the brain is developing, and that portion of our brain and the anterior cortex is not fully developed until we are in our mid-20s. So any exposure from age 5, as this chart suggests, up until age 20, what are the deleterious effects on development which will translate later into behaviors? So adolescent substance use, when does it occur? Well, let's think of our own experiences for a bit. Back in our teen years, I'll give you my own. I think that's not unreasonable. You're out with your peer group. You're now sort of not escaping the clutches of your parents, but you're not under the same direct influence as you once were when you were a child. The peer group becomes extraordinarily important. And so you're at some kind of function, a school dance, or at a party, and somebody pulls out a joint, or pulls out a bottle of whiskey, or a pill, whatever it may be, and decides to pass it around. What would most of us do? Ask yourself that question. Most of us would engage. Does that make me an addict because I took a swallow of 80 proof whiskey when I was 14 years old? Of course not. But I was influenced by my peer group. Now, at age 14, 15, 16, I have no experience. I have no reference point. I don't know that I could be genetically predisposed to the disease of addiction. So experimentation is a cardinal part of human development during our adolescence. 20% of problem drinkers are adolescents. And we can think of that through our own experience for those of us who are engaged in treating the adolescent and the addicted population. Somewhere around 42 million adolescents in the United States. If you do the math, that's 8+ million adolescents with an alcohol use disorder. That doesn't mean that they're alcohol addicted, but they have an alcohol use disorder as defined in DSM-5. So the stages of drug addiction and drug abuse, you know, the terminology can be very confusing. And DSM-4 was kind of easy. You had abuse and dependence. And now you have a substance use disorder. From my perspective, either you have the disease of addiction or you don't. And if you have the disease of addiction, of course, the etiology and the onset and the development I believe, is occurring during adolescence. And it occurs as a result of a variety of things. And we talked about experimentation and risk-taking. But as the adolescent begins to learn that I take a drink, or I use this, or I use that, the reward system says that's rewarding. Now I'm 15, 16, and I'm beginning to appreciate that makes me feel different, makes me feel better. I don't have as much distress. I'm not as anxious. I'm not as depressed. I'm not in fear. To take a drink of whiskey, all that goes away. And because human beings like to feel good, why wouldn't they do it again? And they do. Without the knowledge that they're moving in the direction of biologic addiction. So that there's stages of addiction that we can define. There's genetic predisposition. But that isn't the only story. It's the nature-nurture conflict. Environmental factors, we just discussed some of those. And that's the peer group pressure, the experimentation. I'll take this pill. You know, I often think of the adolescent patients I've had over the years that would tell me about robo-parties. You may or may not be familiar with that. What that is that the kids go around, or the adolescent teenagers go around to their medicine chest and find what's there. And they pour it into a bowl, just like Skittles, and they go to a party and they help themselves. It's called a robo-party. It's also having to do with Robitussin. But nonetheless, that is what's going on. And I think our naivety, unfortunately, has some play in this. So there's a conditioning process over time. And learned behavior says, if I take this, I feel better. If I don't do this, then I feel bad. Host factors, yes, genetic risk, but it doesn't explain the whole biologic process. The genetics are thought to apply to about 60% contribution. Certain personality traits may predispose to the development of addiction. And so-called comorbidities, and what are they? Well, behavioral comorbidities are psychiatric, depression, ADHD, for example, anxiety state, but coexisting health issues may also contribute. Whatever it may be, it is a confluence of a variety of influences that ultimately impact the individual, come together in some fashion that we don't truly understand, change the makeup of the human brain to such a point that now you have a chronic, lifelong, permanent disease that we call addiction. So the inheritance is about 60%, at least that's what people think in terms of studies. Are adolescents more susceptible to alcohol, for example? Well, the answer is yes. Do you remember your first drink and what happened? Now, when I talk to patients, when they had their first beer or their first whatever, they got intoxicated because they had no experience. The brain had no experience with this substance. And so they are more sensitive to the effects of alcohol at that stage. And then, of course, people talk about self-medication and so forth. This is a list of percentages regarding age groups. So the age of onset of first alcoholic symptoms in people later in life that suffer alcoholism. And you can see it clusters between ages of 15 to 24. 39 and 22, if my math is correct, is 61%. Well over half of the population that will later develop alcoholism started their drinking in that time period. They didn't start when they were 40. You know, I use this in conversation with my patients. People don't suddenly wake up one day and say, I think it's a good day to be an alcoholic. I mean, it sounds rather stupid, and it is. You know, go downtown, buy a fifth of liquor, get drunk, drive my car, get arrested, put in the Steel Bar Hotel for the night, and have a good time. I mean, I'm being fallacious for a reason. But the same thing applies, the principles apply to street drugs. People don't get up suddenly one day and look for their street pharmacist, i.e. dealer, and buy heroin and look for a dirty needle and inject themselves. But those concepts are maintained by people, by some people. That's not what happens. The disease has its onset, and what I've just described clearly is not part of that process. So the natural history of primary alcoholism, and these are sort of averages in terms of years of what happens. Left unabated, alcoholism is a chronic, relapsing, and lethal illness. But alcohol addiction also speaks to drug addiction as well. So age of onset, here are some numbers that you can look at. The earlier you start, the greater the risk in terms of not just abuse, in terms of the old terminology, but also dependence or addiction. So if you have your first drink before the ages of 11 and 12, which your children are doing that, whether you know it or not, the vast majority of kids are going to experiment. And it doesn't say all of them do, of course not, but many do. So if somebody has their first drink by the age of say 15, the statistics suggest a 4 times or 4-fold increase in the risk of alcoholism in later life. So the earlier the onset of use, the greater the risk for lifelong disease. The adolescent brain changes. It changes very rapidly in response to addictive substances, including alcohol. There's a change in the neurochemistry, the neurophysiology, and then the neuropathologic process will develop, and that's what we call addictive disease. Here are some examples to give you that most smokers, for example, don't start when they're 50. You know, the tobacco industry doesn't target adults. It targets adolescents. Because if you're going to get somebody nicotine addicted, for example, that's the population you want to market to. Alcohol, most people suffering alcoholism, if you take their history, many will report that they started their drinking in their teens. The numbers are about 40%. So the mean age, as that earlier spike showed you, age 16, 17, at the onset of addiction or the onset of use in the adolescent population is about age 16 to 17, just to reiterate that. And to further note that family and peer influences also play a role in the development of addiction. If parents are using, I have families in my own practice where mom and dad think that marijuana, from the time of the 60s and 70s, is perfectly okay, and they continue to use the substance in their 60s, because they're now in their 60s. Children learn. That's acceptable. Prescription drugs. How many histories do I take from young adults? Mom and dad are on prescription benzodiazepines or on prescription opioids, or a 50-year-old taking D-amphetamine because they have, quotes, ADD. That influence occurs within that environment, and the adolescent may well see that as a norm. Does that influence further drug use and risk-taking? So adolescence is this critical period where we are stepping out in terms of parental supervision. We are influenced by our peer group and other influences, media and such as that. We may be predisposed genetically. We don't know that as an adolescent. You have to have the substance. You have to be exposed to it. You have to have had the drink and other biologic things that may participate in the development of the disease that we don't understand. But all of those things have to come together in the pathogenesis of the disease, just as any other human illness. There have to be circumstances, both external and internal, that will come together in an abnormal fashion to produce the chronic disease that we may be interested in this case with addiction. And this chart just lets you have an appreciation that it's multifactorial. There's no one item that says you are doomed to addictive disorders. Biologic, of course, sociocultural, psychologic, environmental, all of these things come together to influence whether or not the individual is at risk for the future development of addictive disorders or addictive disease. A lot of time can be spent just on this subject, on co-occurring disorders, but there's no question in my own experience and that of those in the field, particularly you in the audience who are dealing with patients on a daily basis. It is not, in fact, it would be unusual not to have a patient that does not have some co-occurring behavioral disorder, be it depression, chronic anxiety state, attention deficit disorder, and other comorbidities. And those influence, at least, but are not causative. I have a lot of people that tell me and say, well, my depression caused my addiction. No, it did not. You can have major depressive disorder as a separate neuropsychiatric illness. Nothing to do with addiction. It didn't cause it. They can coexist. They will influence each other. There's no doubt. But depression doesn't cause addiction. They are unique, specific diseases. And the way I often explain that to patients is to say, can you not be diabetic and hypertensive at the same time? Of course you can. So the neuropsychiatric illnesses exist in their own right, as does addiction, and then there's influence from both illnesses. So psychiatric comorbidity, if you have young adults or adolescents that have depression, for example, and we're seeing increasingly numbers out there, does that predispose to addiction or does it influence the development of addiction? I believe it influences it. I think it increases the risk, but it's not causation. So why do we see such significant comorbidity between the two disorders is a matter of speculation. But there's observations that are made, but one does not cause the other. And yet I'll back up a little bit. Every substance, including stimulants, are depressant. Alcohol's a depressant. Opioids are a depressant after a period of time. Sedatives are depressant. Even amphetamines and cocaine, though they're stimulants, when the individual stops using, they crash into a depression. So does that influence addiction? Yeah, I think it does. I think unequivocally it does. Not causation, but clearly increases risk. So here are some of the common psychiatric disorders that you're familiar with, that we see very frequently, particularly the affective disorders, major depressive disorder, type 1 bipolar. The bipolar illness thing is really getting out of hand, in my view. Cocaine is a stimulant. Xanax is a depressant. Manic depressive illness can look like addiction in terms of the stimulants and depressants that people use. So we have to be careful when we label people. If they're in active addictive behaviors, to make a solid psychiatric diagnosis is very challenging. If that person suffered type 1 bipolar, for example, prior to the onset of use, unfortunately they got two distinct illnesses. And type 1 bipolar clearly it produces higher risk of developing addiction. But using cocaine and using benzodiazepines may look like bipolar illness, but it is not. I found this, and I couldn't help myself with this one. When I was, quotes, a child, we didn't know what Prozac and Zoloft and Ritalin were. And now it's a different world we live in. When I was preparing this presentation and we had conversations and emails, what should we include in the presentation, we felt that trauma was an important issue, which certainly it is. And in my experience, and I'm sure yours, something that's been neglected for a long time. What is the role of childhood trauma and the future development of the addictive disorders or substance use disorders. It shouldn't hurt to be a child. So what do we define as trauma? And this is from the Substance Abuse Mental Health Services Administration. So it's anything that occurs in a person's life that has a negative influence, lifelong, and it can be any of the domains, be they biopsychosocial, spiritual. How are they affected in our youth that has a legacy that continues to occur in our adult life? So there's a variety of, this is not an endless list, but there's early traumatic life experiences that many of us have experienced in our development. Alcoholism, drug addiction within the home, for example. Abuse. I'm seeing, when I ask the right questions in my history, what's pervasive is clear. What I'm beginning to appreciate is sexual abuse. Absolutely the tip of the iceberg. Verbal, emotional abuse. Physical abuse is interesting because as I talk to patients, they believe that getting a good whipping, as they call it, was normal. And it is not. That kind of physical abuse carries a legacy well into adult life. So, and sexual abuse, notwithstanding, is emotional, physical, and sexual all in one. And it's not just girls and women that are being abused. I'm seeing, again, I'm seeing this in my male population as I ask the questions. So the adverse childhood experiences, or ACEs, this is from a study that is a landmark study in 1998 that was supported in California. And the study looked at a population longitudinally to see what events occurred in childhood that would later translate into, let's call them maladaptive behaviors and or addiction in later life. This was supported by the Kaiser Permanente Foundation. And I'll have the reference at the end of the presentation. This is not a list that's endless. It basically gives you an overview of what are considered to produce significant adverse childhood experiences, or ACEs as they're called. And if you look at people in substance use disorder treatment, not just the population at large, you'll find that about 2/3 of them have had a history of child abuse and or neglect. And we're talking a large population. You know, if the prevalence of addiction within the general population is upwards of 15%, one can do the math. This may not show well, I hope it does. This is a simple little form that you can use in your own clinical practice if you're interested in the ACEs and how they affect your patient. You can get your own score with this because you'll come up with this. And so as you increase the ACEs from 0 to 4, for example, in both women and men, the bar graph demonstrates an increasing percentage of those affected in later life. The same is true with alcoholism. The more ACE scores you have, adverse childhood events, if you have 4 or more, your risk of alcoholism is 16% in later life. Add another score to that, it's even greater. And what's interesting about these bar graphs is they're consistent. This one has to do with domestic violence, both within men and women, and you can see that the higher the ACE score, the greater the likelihood of that happening. Smoking in adults, again, the same the same trend is seen. And the number of antidepressant prescriptions that one would observe with 4 or 5 or more ACE scores. So essentially what happens with trauma is it clearly affects the developing organism, namely the individual, in such a fashion is that the neuroadaptive response to that trauma is something that will affect the physical and emotional well-being of that individual through their lifetime, from the time that they are born clearly to the time that they die, and premature death is the rule. So what is addiction? This definition from the American Society of Addiction Medicine, we have to be a little careful with it because it may not be totally applicable to the adolescent population. But it is a biopsychosocial spiritual disease. It affects all four of those domains. And left to its own devices, if this disease is like any other chronic illness that we can experience, left to its own, it is not only chronic, it is progressive, and it is lethal, leading to premature death. You may have, I suspect you're all familiar with this. I included it just to remind us that DSM-5 has come out a lot of criticism. And where we had 7 criteria with DSM-4, we now have 11. Well, I'm of the opinion either you got the disease or you don't. You know, substance use disorder it sounds nice. And I'm not trying to be I'm going to be critical of DSM-5 because what it's taken away is the fact that this is addiction. This is not just a substance use disorder. It is suggesting that if I drink too much, I have an alcohol use disorder. That may be true, but that's not addiction. And then the severities, of course. But we live in DSM-5, so I'm going to have to adapt. Emerging patterns. What are we seeing out there in the communities that we live? In Alabama, particularly in Montgomery, I live in Tallapoosa County, which is just a county or two over, but we're all seeing the same thing. The categories of addiction I've listed, these are some of the street drugs that we're seeing. Some people aren't familiar with kratom, which was very prevalent in Alabama up until 2011, when the state legislature removed it. It was being sold in convenience stores and gas stations. It has a mu receptor. It's a mu receptor agonist, and you can buy it online. You can get addicted to it. People are addicted to kratom. People use kratom to withdraw from other opioids, yet it's not a true opioid in the sense that we think of opioids derived from poppy or from synthetic opioids. Tiana, I had a patient with this not so long ago who he told me that it was worse than heroin, and he was injecting this substance. It's an old antidepressant that was produced in France in 1989, never got to the shores of the United States. There wasn't a market for it. But people have discovered it, particularly on the dark web. Ketamine is probably going to make another showing, as increasingly ketamine is being used for the management of severe recalcitrant depression. And like most other substances, it'll find its way to the street as well. GHB, be on the lookout for it. It's gamma hydroxybutyrate. People call it water. I've had 2 cases recently in our hospital withdrawing from that. And withdrawal can be lethal. It has a marked sedative effect. Just as an aside, if you're engaged in withdrawal management, you withdraw GHB with benzodiazepines and other supportive measures. But it's readily available on the internet and at health food stores. People call it the date rape drug. And here are the prescription groups: sedative, opioids, hypnotics, and stimulants. What's interesting about this group of medications, because they're prescribed, they must be safe. That's the message. And so, just like adults, when adolescents get their hands on this stuff, they think, because it was prescribed to my mother when she's taking her Xanax 2 milligrams 3 times a day, it must be okay. The same is true with opioids. I mean, the opioids are ubiquitous. They're everywhere. Where do adolescents or kids get their drugs from? Well, they're not going into a pharmacy with a prescription and getting 120 Percocet. They're getting them from friends, from the streets. You know, I use the term that you can go to your street pharmacist. The pharmacist may not like that, but you know, I say that tongue-in-cheek. So the diagnosis of addiction. How do we diagnose it? And in my experience, this is from the Big Book of Alcoholics Anonymous, and I took this from there for a reason. We have questionnaires of 10, 20, 30, 40 questions. When I talk to a patient, I ask them 2 basic questions. Can you stop using? Can you stop drinking on your own? And can you limit the amount that you're going to use before you get started? If the answer is no to both of those, I don't have to go much further. Because a social drinker who may be drinking too much, if you say to them, please stop because it's affecting your health, they will stop. They will not drink again. People suffering alcoholism or alcohol addiction may have the same reasons to stop. But as time goes by, their brain may say it just wasn't that bad. They don't know what they're talking about. Those are kind of the responses you get. And that, to me, is clearly is addiction. That's pathologic attachment to alcohol and or other substances. People would argue with me and say that we need to do 30 or 40 questionnaires. I'm not sure if that's really necessary. So how do you assess an adolescent? The same way we do adults? And I'm not an expert in the adolescent treatment field. It's almost become a subspecialty of its own. But the same questions that we would question an adult may not be pertinent to a 16-year-old. So I think we have to be very careful in how we... I had a patient yesterday, he's 22 now, but he started using when he was 14 or 15, and parents have no idea what's going on. And he wanted it very clear that he didn't want his parents in the room when he was being interviewed. He's 22 years old. Well, he's an adult, so he has that prerogative. But a teenager is not going to sit there and say, I'm smoking marijuana every day, and I'm drinking a pint of liquor, and I'm using a little bit of methamphetamine on the side. They're not going to tell you that with a parent sitting in the room. But the parent has to be engaged at some point. Because you need collateral history. You need somebody to say, yes, that this is what's going on. Why? Because of the word called denial. Adolescents have huge denial because they're in a peer group. If the peer group is all using and drinking, that's their norm. It must be okay. So how do you assess it? And here's some of the things that I've listed that may be useful. But there's some basic things we have to do in terms of making the diagnosis. So also look for, in the adolescent population, for the dual diagnosis that we discussed, but also look for rapid progression of disease. You know, they may be starting to use at 12, 13, 14, and by the time they're 16, they are in full-blown addiction. And that's not rare. That's very, very common. And assess treatment. Are you going to habilitate these people or rehabilitate them? Well, rehabilitation and habilitation mean different things. Rehabilitation suggests that I've got the things to work with. You're just going to show me how to do it better. Habilitation means I don't know. And you're going to teach me how to live, hopefully, in a drug and alcohol-free environment. But the treatment has to be comprehensive. It's not doctor and patient. This is a multidisciplinary approach to the treatment of a very complex illness. And the physician may be responsible for driving the ship, but the therapists and many, many others are an integral component of how you treat the patient. So the agents of treatment are listed, but you've got to do withdrawal management. If you're intoxicated or using and you're in treatment, it's not going to work very well. So abstinence, at least in that circumstance, is very, very important if you're going to provide these other measures. And this is the first group therapy. So treat both, but treat the patient, not the disease. Treat their co-occurring disorder if they have major depressive disorder or chronic anxiety disorder, but don't use addictive substances. Don't treat anxiety with a benzodiazepine. Treat their medical conditions if they have any. So, you know, we have to do all of those things and not just focus on that one item, on addiction. People talk about drug treatment of addiction. There is none. There's no drug treatment for addiction. Be very clear about that. There's medically assisted treatment. And these are vastly different. So methadone, buprenorphine, naltrexone, naloxone, etc., those are medications that can be used to treat somebody. You know, buprenorphine has come on board to treat opioid use disorder, opioid addiction. You can't treat a dead person. And it may sound, that may sound facetious, but it's true. So the standard of care has developed where people who have opioid use disorder, because overdose and death is rapid, you may not get another chance at it. So get patients on buprenorphine and or methadone or methadone if that's the route to go. Naltrexone is unfortunately ignored, and yet it's a great treatment. Intramuscular Vivitrol, as it's called, or naltrexone, remains in the gluteal muscle for a month. You can take opioids and nothing's going to happen. It's also very expensive. We were talking about that before the presentation, about the high costs of drugs. Naltrexone is anywhere from $1,200 to $1,400 a month, and who can afford that? Disulfiram Antabuse has been around a long time. You can treat nicotine withdrawal with nicotine. So there are some medications that can be used, particularly to treat withdrawal and to manage and sustain the patient until they can get treatment for their addiction. Treatment outcomes are hard to measure in the adolescent population. Harm reduction is, many of my colleagues and many within the American Society of Addiction Medicine and elsewhere are quite happy and content if you can reduce use. Now, abstinence would be a great goal, but is it realistic? No, it's not. But we should try to go there. But if you can reduce the intensity of use in somebody 16, 17, 18 years old, you've achieved a pretty desirable goal. And you will reduce a lot of the complications associated with the disease. So where are we now? Again, society has its misunderstanding of the disease of addiction, of what it is and what it isn't. But if these numbers are correct, and these are through surveys, about a third, as I've listed, of eighth grade students have used an illicit drug. And what's eighth grade? 12 to 14? Half of seniors have tried an illicit drug, 50%. 27% have used a drug other than THC or cannabis. In my day, back in the 60s and the 70s, 2% of the population had ever used an illicit drug. Now, that's not that long ago. That's 48 and 19. How many? So how are we missing stuff? Well, and again, in an earlier conversation that we had before the meeting, before the presentation, I can tell you unequivocally, in my medical training, I received little to no education in the disease of addiction. And that is true today. As I talk to residents that I'm engaged in teaching, I ask them about how much input have you had with this illness in your undergraduate studies. No different than my day in most cases. Some is beginning to change. Physicians just fail to diagnose it. A lot of my colleagues just don't want to deal with it. And so it's like you're looking at it, but you can't see it. And if you don't know what you're looking for, and then there's this skepticemia, which I put in here. There's a lot of negative misunderstanding that treatment doesn't work, and that is not true. Treatment can be very successful in terms of helping people to get into remission and get into recovery. If you don't ask, you won't know. Urine drug screens, should they be done on all children? And you'll get argument on this. You'll get pushback. Again, that's the practitioner has to decide for their own, but given the fact that these substances are ubiquitous, I think it would be poor medicine not to do a urine drug screen on a child, on a well child examination. The same is true with all psychiatric evaluations. Are you dealing with a pure drug-induced psychosis, for example? Or is that psychosis unrelated to the use of drugs? Well, if somebody's got a lot of THC on board, they may have THC-induced psychosis, or they may have methamphetamine or cocaine-induced psychosis. And these are where you can test. You can do random urine, hair, and blood, observe urine samples. And here are the implications, primary, secondary, and tertiary. And we also just have to get education in the healthcare fields, be they not just medicine, but nursing, social work, the therapeutic community. We all need to be having some understanding of what this disease is and what it isn't. And that's got to start at the undergraduate level, in my opinion. we have a few minutes. Monitoring the future, I wanted to touch on this just for a little bit. This document is available, excuse me, online every year. And this is the latest publication, 2018. And it has been around since 1975. It is funded by the federal government, conducted by the University of Michigan, and is an ongoing study of 8th, 10th, and 12th graders. Started off with only high school seniors in 1975 and then has progressed to looking at the other age groups. And it's a national survey of drug and alcohol use in the country. This graph, and I can't see it to comment on it, but this looks at the use of substances other than marijuana. And I think what's interesting is that the parallel lines that are occurring, you see that throughout each graph. What does that suggest? Have we reached a steady state of drug use? Is that the implication within that population? And this is other than marijuana. Substance use disorders, as looked at last year, and these are estimates, the true numbers probably will never be truly known, but there's 21.5 million people aged 12 and older that have a substance use disorder in our country. I think that's a heck of a disease burden. Adolescents, 1 in 20, and I think that's probably an underestimate in terms of the incidence. Opioid use, these again are numbers that are built based on surveys, and yet the whole opioid epidemic is an underestimate of morbidity and mortality because we often don't measure. We don't do forensic studies on decedents, for example, who have died from opioid overdose. But at least this gives us an appreciation of the gravity of the situation. Where do kids get their opioid analgesics? Well, free from a friend or relative, and from the medical and dental professions. There is absolutely no reason, and this is to my dental colleagues, to give 30 Percocet for somebody who's had a tooth extraction. It makes no sense. A sprained ankle doesn't deserve 20 Lortab, but that's what we do. This chart taken from this study is the annual use, risk, disapproval, and availability of heroin. And we can see that it's declining in terms of availability to this population. The risk is considered high within the adolescent group, and that is a good thing. This one is narcotics other than heroin that are, and they're on the decline. So we're seeing some improvement, at least over the years, from that peak of about a decade or so ago in the grade 12 population in terms of opioid use. This caught my attention a few years ago when the FDA thought it was a good idea to prescribe OxyContin to children as young as 11. With what we just discussed about the risk involved and the not understanding the genetics, in the genetic risk, why would I want to prescribe a highly addictive substance to an 11-year-old? Very quickly, we'll just talk a little bit about marijuana. Why? Because it's coming to a state nearest you. Our neighbors to the north in Canada, it has now been nationalized. It's there to use. So states in our country are gradually going to get into this because there's too much money. And this is what we're talking about. Already we're seeing stores popping up. If vaping is not bad enough in the adolescent population, and vaping THC, we're seeing little stores pop up with not GHB, with what's it called? I'll think of it. It's a benign substance from cannabis. My goodness. Anyway, marijuana. What's the deal? Back in my day, marijuana may have been 1% THC. Today, what are we dealing with? As high as 15% in plants. This is an hallucinogen. And in edibles, it's 30, 40, 50 or more %. So we're exposing a developing brain to a substance that has far-reaching effects. Is it a gateway drug? Well, if you've worked in the treatment industry or the treatment world, 60% of teens allegedly are there because of cannabis. Marijuana and adolescents, again, 60% had their start with the use of marijuana as a precursor to the use of other substances. This is an old graph. What it says, as risk goes up, the use of a substance goes down. We have that inverted today. Use is going up because the perception of risk is going down. Talk to your adolescent population. They will tell you unequivocally, as far as they're concerned, cannabis is not addictive. That is the perception that they've obtained from where? And you can answer that question for yourself. Psychiatric issues are becoming increasingly concerning. Since it's an hallucinogen and it produces psychosis, a lot of people are talking about whether or not high-dose THC in cannabis can predispose or can promote the development of psychosis or psychotic symptoms, particularly with schizophrenia. And so there's increasing concern about this. The literature is not definitive. You can't do a randomized, double-blind controlled study on this. But observations, if people are seeing this in the population, then I think we need to take note of it. Schizophrenia and marijuana. Is there a relationship? Well, the emergency rooms are seeing more and more people coming to the ERs with THC intoxication and psychosis. Is it a gateway drug? I thought it was cute when I saw it, but it's not so cute. In essence, there's a lot more to the story, and the references are available to you if you like. For those of us in clinical practice, often I feel like, as a physician, as an addiction medicine specialist, I got a finger in the dike, because we haven't seen anything yet. We're talking about an opioid epidemic. What we have is an epidemic of addiction in our country, both prescription, licit, and illicit substances. And the starting point has to be somewhere. That's not to say that all addiction starts in adolescence, but the vast majority of patients that we treat, that was the starting point. That was the prodrome. That was where the pathogenesis occurred. And then the ultimate disease set in over time into the adult population. I think I finished on time, didn't I?
Sir, I'm not seeing that we have any questions, but I do want to thank you for sharing that with us today.
Well, thank you for having me, and I appreciate very much for the opportunity to be here and share with you a little bit of my experience.
Sure. This concludes our program for today. Please remember that you can refer back to the training and the resources anytime on demand. Have a great day.